All right, and John, you can take it away.
All right, thank you very much, Matthew. It's good to be back with everybody today. We have our same faculty that we did last week, and we are delighted to welcome Dr. Jessica Kalender-Rich and Dr. Maria Fox from the University of Kansas Medical Center to share with you guys today on some of the issues related to advanced care planning and its impact in the long-term care setting, especially as we face the COVID pandemic and the vulnerable population that we all take care of. So thank you again for joining us, and we'll try to get through the content a little bit quicker this week than we did last week and have 10-15 minutes at the end for us to be able to share some Q&A with you. Next slide, please. So again, Maria and Dr. Kalender-Rich are both on faculty at the University Medical Center and also work in the hospital at the University of Kansas Health System. So we're delighted to have them. My colleagues, Linda Ward and Terry Roselle, are also on today. Linda presented last week, primarily focused on the interventions of families and discussions with families, kind of on the non-clinical side. But today we're really going to focus on the clinical side. So as we talked briefly last week, this is a global pandemic, really kind of a national disaster that we've been dealing with, an emergency for the last few years, months, excuse me, feels like years. And we are obviously still under a state of emergency, and all of us dealing with kind of at an institutional crisis level, and obviously face-to-face with our patients and families. Next slide, please. So again, quickly to review the objectives, these are pretty much the same as last week, to identify the critical thinking, the critical ethical considerations that we have, especially for this at-risk population, the highest at-risk population, other than those in prisons. Explore the challenges and risks of congregate living as that relates to COVID-19, so not just long-term care, but any kind of, nursing home, but also any kind of congregate living. To recognize that the provider's duty of care is not necessarily admitting defeat or failure in the face of this, but to prepare families and to prepare the residents for the considerations that are important should, for any reason, they have to go to an acute care setting and face the risk of having an outbreak in their own facility. And then finally, to really focus on our own personal responsibilities and also working with patients and families and residents in helping them actually differentiate between values and what's most important for them as we then identify goals of care. So last week and today, we addressed the issue around the urgency and the need for the interventions in long-term care that we're going to be talking more about today. I wanted to reiterate again the importance of differentiating the roles of the resident and the family and the responsibilities we have in helping them explore, describe, articulate their values, and then the clinical support that is used then to help them address those discussions and the impact on a crisis situation. So it's about my job, your job, and our job together. So the first thing that we talked about last week, and we continue to reference today in the resources that we'll be sharing with you later, is that the identification of the patient's values and the meaning and the preferences that they have through advanced care planning is really the work of the resident and the family. Though it may be facilitated through a clinical support system, it is still their job to identify those values and meanings, and not ours. And our job is to elicit and clarify. And that is all related to our duty of care to them and their duty of care to each other. The resulting outcomes then get translated into goals of care, which is really what we're going to focus on today, and then documented into those treatment plans and medical orders. So that's the real role of the job that we're doing together with them, is to take those vernacular or those common language themes that they have around meaning, importance in life, values, those kind of things, purposes, and translate them into treatment preferences. And then finally then to do the fit and the match related to the clinical conditions that the individual has and in the uncertain environment, especially when an outbreak may occur in the facility, because obviously the risks increase dramatically. Next slide. So our job is to deploy the tools and elements of good advanced care planning. We know they exist. We've got good evidence-based resources. We've shared some of those with you last week. We'll be sharing them again this week. And that there are tips and tools for residents and families to use, as well as caregivers. and there's good resources for us to use, and we want to make sure that we are putting them in your hands so that you can deploy them. And then to discuss the clinical importance of how knowing values of those individuals impacts the treatment utilizing the goals of care discussion, which is again, basically a skill set that Dr. Kalender-Rich and Dr. Fox will be sharing with us today. And finally then, to look at the possibility of identifying cloud-based tools to assist with that communication in either capturing, recording, storing, and archiving it, and then retrieving it. So what we jointly have to do, and our collective effort, is to really be humble about the way that we approach this, to ask, to listen, to confirm, to be able to report, record, share, and retrieve. Those are all very important aspects of this. We're going to be talking about how to do that within the clinical record today, and being able to share those commonly and widely. To engage in serious conversations using that common language, and though we may have responsibilities in helping translate that into medicalese and legalese, it's not the job of the patient and the family to do that. That's our job. And so focusing on the families and the residents' importance of focusing on values, joys, meaning, purpose, those kind of things, beliefs, the importance of faith, that's what the clinicians are going to be relying on for them to be able then to elicit and translate those. Then finally, for all of us to know that the vulnerability that we face, the fears that we have are real. They impact our readiness and ability and confidence in being able to do this. That's why we're going to use crutches and scripts and drawing on the strengths from the shared struggle. And I know that both Maria and Jessica are really, really good at this. And I deeply appreciate their commitment to kind of coming at this from the human level. It's so important to the residents and families we serve. Okay, with that, I'm going to turn it over to Maria and let her take it from here in terms of the responsibilities that clinicians have in making sure that advanced care planning is received well and integrated into the goals of care. So Maria, take it away.
Thank you, John. And before I get started, I really want to say Happy Nurses Week to the nursing colleagues in our audience. This year, even more than other times, it seems like we really need to give you a lot of energy and support, and hopefully a lot of thank yous for what you do. So Happy Nurses Week. I'm going to take a few minutes here to really kind of set the stage for what Dr. Kalender-Rich is going to go into more in depth. And when I thought about how this was important in terms of advanced care planning, I really called it just the basics. And I shared with you last week, I'll reiterate this week, that almost my entire background was in critical care nursing. And I really thought I was a great communicator. But when I came to KU on the palliative care team, I realized, as John said earlier, there really is a skill set in having these conversations and communicating. While I thought I was a great communicator, because I did so many things in critical care nursing, I really had to learn. I had to train, I had to get feedback. And I know Dr. Kalender-Rich was by my side often, and we would share like this worked well or that didn't work well. So what I want to share with you is really some of those basics that we know through different training programs, through different literature that's out there, that these communication basics really work. The tools, the formats for advanced planning may look one way or looked one way pre-COVID, may look a little differently post-COVID, and Dr. Kalender-Rich will go through that, but the basics are still there. You might have to do it a little quicker in shorter time with less of that ongoing, revisit, but the basics are still there. So that's what I want to share with you. Next slide. So I will revisit this slide from last week. Here are the goals for advanced care planning. It really, first and foremost, maps out the plan for whatever future interventions or treatments is coming down the pike for the resident, for the patient, or really to discuss with the family as they're talking about their loved one. But these advanced care planning conversations really happen best for three main reasons. They should occur before a crisis, okay? And the reason is, for one, you want to avoid intensive life-sustaining treatments when it's not wanted by the person, by the patient, by the resident. The second reason is we don't want to implement non-beneficial or unwanted high-intensive interventions during periods like this, like a pandemic, like a crisis. And thirdly, we don't want to provide those non-beneficial or unwanted interventions because it probably may place others, like our providers, like our caregivers, at higher risk of transmission. So best to have these advanced care planning conversations before these crisis events. And really, the goals are to clarify that diagnosis, know what's going on with the patient, what are the conditions, know what it means in terms of what those future interventions and treatments are going to be, and really then, what can we expect out of their longevity or treatments and outcomes. Next slide. So I do want to tell you, and those of you who may not know, when I came to KU, I embarked on a project with Dr. Porter Williamson and a few other folks in the health system. And that is that we wanted to improve training for all providers, not because, we thought somebody could do it better than others. We know that the ones that do it the best are the ones that do it all the time and frequently. But we also knew that there were a lot of folks out there that were having conversations with patients and families, inpatient, and I'm sure you can say in the long-term care facilities as well. So I embarked on a project to bring to our facility the End-of-Life Nursing Education Consortium course. And so you'll see that that's where I got my talking points from that curriculum. And it really is a comprehensive education program, but in that as well, there's all sorts of tools that are available. But some of these things I'm going to share with you again are very important to consider in any conversation at any time when you're having with residents and families or patients. And so so take these away with not just the tips and maybe the words that go along with them, but also consider the setting and the time frame that you have. When we set up for these conversations, we sometimes take our time. We make sure we've got the right people and all of that. But other times we might not have that time frame available. But remember that these techniques are really important all the time. And the first one there is to build trust. It really is important, that the trust that you have, whether you're a provider, whether you're staff, nursing aides, or social workers or nurses in the long-term care facility, patients and families want to have that trust with you. So it's really important that that's at the base of the conversation. There are some other techniques. One is called the warning shot. This is one of those comments that you can make deliberately and really use the words, I regret that I have some difficult news to share with you, especially if you're going to have a deeper conversation with that patient or family. Acknowledging emotions, very important. I think this is part of that, the empathy that every one of us has to develop as well. And to be able to see it and reflect back. I see this is very upsetting to you. It's important to legitimize the normalcy of the reaction, whatever that reaction may be. Sometimes it's good information, sometimes it's not. But to be able to legitimize that it's normal. Anyone receiving this news would be upset, or would be confused, or would be concerned. So definitely looking at the person that you're giving the news to and try and legitimize their reactions. Then to explore what is under that emotion. You can explore with just this question, and this question helped me so much in my communication skills development when I was with palliative care. And this question was, what worries you the most? When I would use that question, that would open up a whole plethora of questions, a whole nother dimension, if you will, for me, and by me just asking that simple question, what worries you the most? Empathy, again, very important. I cannot imagine how overwhelming this is. And also to acknowledge whatever strength or good coping skills and mechanisms the person has in place. Where do you find the strength? Something simple and straightforward to tell the person. And then really using silence. You know, we know that often as providers, physicians, APPs, or others, we tend to dominate the conversations. We know that. You know, there's been studies that have recorded providers, and often that's who dominates the conversation. But often using silence is a very key communication skill. Now, all of you know that, you might know, 80% of communication is nonverbal. And that's really important, especially as we get into some of the more deeper communication styles and skills later in this seminar, because often we're having conversations with patients and families with masks and shields and gowns. So oftentimes it's the nonverbal that we're portraying to patients and families. Next slide, please. Some other techniques. Check that your message has been heard. And you do that by asking, what have we not talked about today that is important to you? What have you heard? Or what did, you know, repeat back to me, really, is one of those techniques you can use. Using the D word, that's a toughie. That's one I learned along the way. It is important to use that word. Because you are so ill, because your mom is so ill, I think she is entering that dying phase. I believe you are dying. It really, you know, to use reverent tones is really important. To use very respectful tones is very important. But at the same time, it is better to use that word than to use some of the other words that might have different meanings to different people. Expect conflict. You know, that will happen, especially if words are misunderstood. And then important to summarize or restate your understanding. Let me double check. Let me see that what I understand you said was, all right? And then provide support. Provide that support and just saying, I'm here to work with you and support you. Nonverbal, we talked about that already. All of these tips and communication skills I had to learn. I had to learn through training, through repetition. I had to ask, you know, when I was working with someone, and we would often work in teams, to say, did I say that the right way? Or when I said that, did it come out as it should have? So don't be embarrassed. Don't think that really, I did it an awful way, but really just ask your colleagues or ask your patient or family, did that make sense to you? Did you understand what I said? And they will tell you. They will tell you, because again, communication is so, so important in these conversations. Next slide, please. I do want to dwell just a minute or two on the I'm sorry versus I wish. And I will share with you that I was a very commonly used phrase for me is to say, I'm sorry. I use that all the time. I'm so sorry. I'm so sorry we have to meet like this. I'm so sorry I have to tell you this information, or I'm sorry that I bothered you. And there's certainly some schools of thought around this. I think what I want to share is that I'm so sorry needs to be used, but with great caution, because it can be misinterpreted, especially if it's used quite frequently. Sometimes it comes off as aloof or showing pity, or really just not meaning as you want it to mean. So making sure to use I'm sorry with discretion. Now, I wish statements do demonstrate just a little bit more empathy. but they also place some limits on what can be done when you're discussing interventions or treatments. I really wish we had better treatments for your disease. I wish I could tell you we could do everything, but the limits are X, Y, and Z. So just a little bit about I'm sorry versus I wish. Next slide, please.
And maybe before we advance, we got a question a little bit ago that ties in nicely here, that is just inquiring whether or not we think that empathy is a skill that can be taught.
Oh, I've heard, and anybody else on the panel can weigh in as well, but I've heard that people believe they're either born with empathy or not. And I'm not an expert in all of that for sure, but what we try and do in some of these education courses that we do have is to use those words that would portray that empathy. I do believe that our people that can communicate really well, and there's probably lack of empathy in that. And without going into that further, I think we could probably teach the right words and hopefully teach the right nonverbal communication styles that go along with that, but definitely something we all should work on if we're working with patients and families, especially dealing with serious illness. I don't know if anybody else wants to weigh in. Good point, though.
Jessica?
Empathy, I mean, I would agree with you, Maria. I think that many more people have empathy than we recognize. And so sometimes we just need to unlock those skills and uncover their ability to portray what they're actually maybe feeling. And that can be the hardest thing. I do believe there are some people that just lack empathy. I tend to believe those people don't end up in healthcare very often, but or at least I hope. But either way, I think I think it feels to me like there are a lot of people out there for whom education and experience can unlock those qualities so that they can provide that type of empathetic care for the patients.
Yeah, there are a number of studies that indicate that folks who are, as you say, Maria and Jessica both, that the repetition, the exercise of using the words to help you kind of develop the language allows you to kind of separate yourself from the shields that we put up, the natural defenses we put up related to this. So there's a very part of that, being able to use those words in a way that allows us to put down our fences. There's also, the cumulative loss issue that affects the ability of people to shield themselves, again, the defenses. So we've got to protect against that as well. But an excellent question. But again, I think your counsel about using the words and checking with others to see how you're doing is a great way to address the issue. We're all human, so.
All right. And again, this is a review of last week. I think I looked at, and there's many tools out there to help with those conversations. And, you can even Google or search family meetings. There's been a lot of work put into the structure of a family meeting. And, for some of you, that's been my biggest work professionally, because again, as I told you at the beginning, I thought I was a great communicator, and being in critical care, we talked with families a lot and, had these conversations, but really when I started working with a palliative care team, did I realize that the family meeting is really it's like a procedure. It really warrants some careful thinking of how that family meeting should go. And so again, we need to continue with some of that framework, and no matter what we're having conversations about or what we're going to discuss. And it may look different pre or post-COVID, but I would like to think that these same important steps are in place. And really the first is you've got to prepare for the meeting. You've got to know what it is you're going to discuss, whether it's, the condition of the patient, whether it's, really just to update the patient or family about what's going on, but preparing for the meeting is really important. And that it means, if you have the time and the luxury, do you have others you need to include in that meeting? Do you, need to make sure a specialist is there, or the patient's attending, or certain family members? Those are all, you need to think about that in terms of preparing for the meeting. Open the meeting with introductions. It's really important to know who is in attendance, and who, especially if you're doing any family meetings via Skype or FaceTime, really knowing who's available. I know right now we're trialing some Zoom and Skype meetings with students, if you will. So it really is important to make sure that the patient and family know who all is attending. It's important to establish the goals of the meeting. And maybe really the goal is just to give information, or you need to make a decision or have a decision about something. But be prepared for the goals of the meeting to change based on whatever conversations happen during that time. Elicit understanding of what does a patient or the family know about their condition, their prognosis, or even, what's going on in their clinic, in their setting, in their long-term care facility setting, versus what's going on outside. Those are the kinds of things that are really important for you to know about in going into this conversation. Elicit patient and family values and goals, very important as well. And I think you'll hear more of that as we get into the conversation. Deal with the decisions that need to be made. And sometimes the decisions may be, we need to come together again in another week, or we need to decide about, Dr. Kalender-Rich will go through some of the critical decisions that are needing to be made in this pandemic period. Close the meeting with, some hopefully some clear-cut guidelines as to what's next, making sure we're going to do this with the code status. We're going to write this in the chart. We're going to make sure other families or other providers are notified of, and then follow up on that meeting, if you need to get a hold of somebody else or another provider or specialist. And so when you look at this slide, and I think Matthew will share these slides, these are all very important processes or steps, if you will, in structuring the conversations that you're going to have with residents and their families. At this point, I think Dr. Kalender-Rich has a whole lot more to share. Thank you for your time.
I think you're still mute, Dr. Kalender-Rich.
Man, I'm always making fun of people for doing that. I just wanted to say thank you, Maria and John, for your introductions and your time. If you could go to the next slide. I think it's really important for really the whole healthcare community to understand how long-term care works, because it does not work the same way that lots of other healthcare settings function. And that's because there are different types of people doing different types of things. The administration and the nursing teams have a huge role in the direction of care. And there are a ton of regulations. And so, I just threw this regulation out there because I think it's important for us to have, just from a basic understanding, right? The government will come in and they want to make sure that we have done advanced directives, had written policies that people can refuse or accept medical or surgical treatment, and created an advanced directive. Now, that can mean so many different things. And that also means it's done in so many different ways, in different facilities and in different levels of facilities, whether it's memory care or long-term care without a memory unit or assisted living or whatever it is, with full recognition that assisted livings don't have these same regulations. But we are all operating under really unique circumstances and are forced to make decisions that fit with our normal, and our new normal. And so if you could move to the next slide, please. I want to talk a little bit just about like, what does advanced care planning look like now? Right. So I've worked in several different types of facilities over the years, whether it was hospital, clinic, long-term care, assisted living, memory unit, all those different independent living, all those different places. And they are all really different. And they're different based on how many patients there are. They're different based on how many different kinds of providers are coming into the building, right? A building that has one physician team or one nurse practitioner, PA, or whoever team is going to look different than a building that has 5 different groups coming in and seeing different patients. And also their levels of involvement with the administrative team can be very different. And maybe most importantly, is the experience of the social work team, the social work provider in those buildings. Because all of these people have different pieces to play in the advanced care planning of those persons, and all of those different people come to it with really different skills. On top of which, we are really used to, and I've said this before, making these decisions and having these conversations over a period of time, right? We meet, we have a nice care plan, we go back, we talk, kind of like Maria just mentioned, right? We go back, we might revisit it the next week. We have the time to really sit and think through what might need to be done. And we are now in a setting where, or a condition where we really need to think through those things while someone is very stable, but in the event of a really serious viral illness that could come at any moment. And that sounds really kind of foreboding, but that's what we're here to create a safety net for, right? Like all of these conversations are about creating safety nets. If this happens, we do this. If this happens, we do this. And having a safety net that is specific to COVID might look different than our normal safety nets do. And that's potentially right. Next slide, please. So we all know these things look really different. So Maria was describing like the best situation, right? We have a great family meeting. We might pull in the specialists. We might be on Zoom with like the whole world there. And I've done those, right? Those are synchronous visits. Those are visits where we can have a care plan or a family meeting, advanced care discussion that includes sometimes the cardiologist who's off site and the daughter who's in California and the son who's at his office and the resident and me or an advanced practice nurse. But it doesn't always work, right? So while that's ideal, because then everyone gets to hear what is going on, asynchronous visits can work too. And in asynchronous visits, they may take a little time, but they can work really nicely if the whole team is working together, right? So I've had times where I might call the cardiologist in advance of the meeting, and social work might speak to the family, and nursing might speak to the resident, and then we can all bring that information together to speak to whomever. And I'll go through that in a little more detail later. But the truth is, it doesn't matter if you're all in the same room together, or if you're never in the same room, or even if you're never on the same technological platform. What really matters is that there's really, really good communication, and there's really, really good documentation that uses the patient's words. Because using the patient's words in that documentation means that when you're in the setting of a crisis, and the nurse from the facility calls the family to update them, and the family says, oh my gosh, I want you to do this, and this, you can say, I think that we can do those things, but I just want to remind you that when we had this conversation, your loved one said, and then you have a quote. And it's not that nobody can change their mind, but it does empower that family member or that patient or you as their care provider to know what was said when everything was calm. Because that information is really what should drive our plan. That's where our goals come from. So if you could go to the next slide. The goals always drive the plan. So that means in advance of anything big and bad happening, we want to know. And by the way, the best place for this information is from the team members in the facility if the resident can't tell me themselves, right? I want to know, do they love being able to go to the church meeting either on site or at the actual church? Do they like look forward for the whole week to seeing their grandchildren come visit them and bring them a chocolate bar or whatever it is, right? These are the things that make people happy, and those things help us know how their values fit in with how they live their lives. And there's no best person to identify their goals, right? The patient or resident is obviously the best person, but all of this other information feeds into that. It definitely isn't always the doctor. It can be, sometimes it is. But man, sometimes it's the aide in the long-term care facility that has seen that patient every day for the past 2 years and knows what kind of breakfast they like and how they like everything set up, and might sit and talk to them for 20 minutes a day. That person might know more about the patient than anybody else. And that's great because we need that information in order to know their goals, in order to make their plan. Because once we have those goals, right, then if you tell me this person feels like quality of life is being able to read the paper and then discuss it with their neighbor at the breakfast table. And then 3 months later, if that person has some sort of catastrophic stroke where they are not going to be able to do that, we can know what to do, right? And we can extrapolate from their goals to those things that are listed on the slide. If the person gets sicker, would they want to be hospitalized? Would they want to be intubated? Would they want cardiopulmonary resuscitation to be attempted? And these goals can be for all illnesses or they can be COVID specific. It's important for us to all recognize that in the setting of COVID, and this is why these conversations look a little different, but in the setting of COVID-19, hospitalization for the frail older adult population does not tend to change any of the outcomes. And the rate of dying is very high. And the things that we can do for them in the facility might be the things that help them stay in their home. And maybe even if they were to leave and go to a strange place with strange people, it might not change anything. Next slide. So my favorite place to do this is care plans, to start the conversation, right? So if a resident has been declining, or if the therapy team, if it's a skilled patient, has been not improving as well as possible, it's a really nice place to sort of bring everyone into the conversation. So like, and for long-term care, it's critical. The nurse that takes care of them or the aide that knows them well is always there. And there'd be a leader of that conversation. And the leader can be anyone in the room, but they have to follow the steps. And I love how Maria actually shared a lot of those steps with you. And those steps can be done quickly or they can be done slowly. Sometimes it depends on the family or the patient, obviously, right? Like the person who really needs you to spend a lot of time building rapport, that person needs slow steps, and that's okay. But other people already kind of know and they're ready to sort of flip through, and those people you can move quickly through those conversations. My personal preference is that before any of these meetings happen, right, everyone has looked at the chart. Everyone has talked to the therapy team if they're involved. Everyone has talked to nursing, the social work, and even the billing office, by the way, right? So that may not be specific for COVID, but it's important that we have the billing office in mind, because if people are switching for payers, or they're going to think about hospice, or they were on skilled care, that can change all of those different pieces. And for us to have a conversation, we have to really know it, because we don't want to drive them down the wrong path without information. So now we have talked through sort of the, hey, this is how we do this currently, and it's really nice and slow, and it involves lots of conversations. And on the next slide, we'll switch to, okay, but wait, how do we do this with COVID-19? Because this is different and it has to be approached differently. And there are things we have to talk about in advance. So it feels very strange to say to someone who's at their functional baseline, but hey, what if you get this virus thing that you can't really comprehend? What do we do then? And it's important to remember that underlying all of this is that the goal drives the plan. Next slide. So we can still have care plans. We can still have family meetings, and we should, by the way, still have family meetings. But more likely, we're not going to sit down with the whole team and have all these conversations, because the truth is, we need to be going into all of our buildings and having the conversations with really everyone. We need all of these things updated. And so it's good on the next admission or on the next routine visit for the physician team or the provider team to go in and really talk to the resident and their family about these. Everything should be updated in the setting of COVID-19. And I'm speaking as a physician in this setting, we sometimes need cueing to do this. And that's okay. And so we might need to know what things are being discussed, what you have seen. We might even need you to make a template, right? Of, hey, I made this template, this might help you. Or, hey, I noticed this, here's a piece of paper that lists it out. Because it's important to really get your whole provider team on board with, okay, but in the setting of COVID-19, is this person a DNR or full code, right? So if their body passes away, do we try to bring it back? Are they a do not intubate, or would they want to be intubated in the setting of respiratory failure? Would they want to be hospitalized? And who is their surrogate decision maker? And the other pieces, all those 4 things have got to be handed to the EMS or the emergency department if that patient goes out. And that's always true, but that is even more true now in the setting of COVID, because they do not have time to look for that information right now. Patients with COVID-19, if they get so sick that we send them to the hospital, they get sick really, really quickly from that point. Next slide. So I'm going to go through some documents. As John mentioned, there are lots of decision aids out there. There are lots of sample languages. These are the ones that my group is using. They are based on some language from Adriani Labs. I always say that wrong. Probably did again. And Ariane, anyway, and so we'll go through those, and then they were adapted by some of my team members at the University of Kansas Health System, Dr. Lori Olson and Dr. Christy Bartlett, and they've allowed us to share them. So I would encourage you to, I'll go through them. The slides are actually really hard to read, and that's because there's a lot of words. It's kind of intentional that there are a lot of words. But if you request the slides from Matthew, you'll be able to see them more long-term. And then we'll be able to sort of go through some different samples. I'll do it a little bit quickly because we want to leave time for questions, but you'll have these. Could you go to the next slide, please? Thank you. So there are several different types. So first of all, this one is the goals of care with a non-medically frail person who has COVID-19. You are less likely to use this, so I'll go through it really quickly, in the long-term care setting, because our population is medically frail. These are for like your people, maybe your staff members. This is the type of language that's most useful for them. But I will point out at the conversation setup, and these all go through the same sort of structure. The conversation setup is, you just say, I'm very sorry that you have COVID-19. And I want to ask you how you're feeling, right? So it's just sort of a quick established rapport, and then tell me how you're feeling. And then you can move down from that with these folks that are really not medically frail and pretty consistently cognitively intact. If you go to the next slide. So this is a Clinician Guide for Goals of Care with Medically Frail Individuals Who Have COVID. So this, for us in long-term care, is really in the setting of an outbreak and kind of a rapid movement through the long-term care of getting these conversations done quickly, knowing that there's a really high likelihood that you either have COVID-19 or that you've been exposed. So it again starts with tell me how you're feeling. But the next thing, this assessment of understanding on this one is like, tell me what you know about how this is affecting people like you. Right? And that really can open the door. I've used this phrase several times, and it opens the door for people to tell you what they know and what they're thinking so that you can either validate it or you can refute it, frankly, or that you can take what they say about it and really expand and often jump different lines in here in order to make sure that you're covering the right information. The next slide actually is probably the most important. Again, it's set up very similarly, but this is the one to do before there's an outbreak, right? This is the now slide. So for medically frail individuals that don't have COVID-19, right? I'm going to check with you. I'm going to check how you're doing during this stressful time. That's the setup of the conversation. And then tell me what you know about how it's affecting people like you. And then I like to point out this this way in which they identify preferences. So I really like to do this a lot. So there are some people who would pick this option that are okay with going to the hospital and getting oxygen in the hopes that their body will recover from the illness. And there are other people who would say, you know, I think that what you can do for me here is really what is the right thing, and I'd rather stay here. And then I say, do you know where you kind of fall in that category? Right? Or you can rephrase it for the family member if that's who you're needing to speak to. And you can gather a lot of information from that that supports the things that we mentioned that you need. And as you move down the list, it's also really nice to make sure to identify the healthcare surrogate if that's not already done. And I would encourage you to make sure that the one that's on file is actually the one that they still want. And then B, make sure that everyone knows you're going to tell their surrogate if they're not present with you. I will say that I just had a meeting the other day. A bunch of people were complaining about doing telehealth and Zoom. It really has let us have these conversations in the nursing facilities and actually get people there. So from that standpoint, it's actually really helpful. The next slide is a really tough one to swallow. This is some sample language for calling family when their loved one is dying. Now, we know that in long-term care, we aren't letting visitors in, but there are some special dispensations for patients who are actively dying. That being said, in many cases across the country, either of these things are happening really quickly, or family can't get in town because we're all locked down somewhere, or they're afraid to come into the facility and get sick themselves. There are all kinds of reasons. So this is actually a really nice script for helping people say goodbye over the phone. And that is even terrible to say out loud, by the way. Like, it feels really yucky. But I'm sure that everyone has seen on the news people doing this all over, and it might be the best we can do. And to provide people that amount of closure can perhaps be our, the best that we have to offer sometimes. So I'll encourage you to look through that at some point. I have two more slides. The next one is the life support decision aid. So this is really a way that people can think through, man, what would I want when it comes to life support, right? And the challenge is, I think we often think of life support as life-saving instead of life support as life-supporting, because all it really does is give us that support while our bodies try to get over the hump of whatever underlying condition exists. And so this sort of helps explain the different pieces comparing life support and comfort measures. And it's important to point out that they use the D word on both sides and multiple times, frankly, because if someone is this sick, then obviously they're at risk for dying. But it's also important because when we are talking about comfort measures, sometimes we make the mistake of saying we're going to make you comfortable without being clear that we're going to make you comfortable and allow you to have a natural death, right? Which is a really different statement, in order to make sure that sometimes our people with mild cognitive or even moderate cognitive impairment really understand what we're talking about. And then lastly, is code status decision aids specifically for those with COVID-19. Now, it is challenging in the long-term care to code people who are COVID positive because it is an aerosolizing procedure, and we have to be really careful with aerosolizing procedures. So you should certainly speak with your facility and make sure that there's a policy in place for how you're going to do this, because you are, of course, still going to code the full code person, and you are still going to not code the person who is DNR. That being said, as you read through this, it really just helps patients, family members understand what the different pieces are, because there is so much media out there that sometimes conflicts with what we as medical professionals know to be the accurate pieces of how this works and what it looks like and how successful it may be. I'm going to turn the mic over to John to sort of wrap us up and hopefully get a couple questions in.
Okay, thank you very much. Very helpful information from both of you. I really appreciate it. I just wanted to maybe in a couple of minutes here point to a number of tools that we have in addition to those that you just cited on the website. So these are the 6 categories that the resources that the center provides to all of you for being able to assist in these conversations or develop these discussions. The first one is guides and prompts designed for consumers. So this is basically for the families is the first category. Decision aids are sometimes included in that and sometimes not. So there are some tools that will, one I'll bring up here in a minute, which actually allows the individuals, the residents and family members to have a discussion prior to a clinically facilitated conversation about the treatments that Jessica just covered. Provider facilities to have the discussion and clarifying goals of care are also some of the tools that we have. Medical orders, as you just discussed, and then documentation and the recordings for being able for the people who can't be on the phone to be able to record those and store them and retrieve them for family members. There is a My Directives tool, which is a cloud-based system that allows us to do it. And then finally, the Caring Conversations tip sheet that we have available in terms of, again, facilitating a discussion with family prior to a clinically facilitated discussion. Next slide. So Matthew, if you want to go ahead and activate this, I just want to bring up 3. This is what you will get. These are directly on our website. They automatically populate under this category. So there'll be about, I think, 9 or 10 or 12, whatever there are now, in terms of the specifics. And these are all COVID specific related issues. So these are the different ones. So I do want to point to two or three. First of all, Matthew, if you do the respecting choices one quickly, these are kind of some of the tools that are available through respecting choices, and you'll scroll down and click on, there's a decision aid on the left-hand side there. You'll notice that there's care planning tools, proactive care planning, medical decision-making, and then specific treatment decisions related to CPR and breathing. So if you want to click on that CPR one, it's the same kind of thing that Jessica just went through, but it's really designed for the individuals themselves. So go ahead and go back, and we'll pick on the one on the middle one there from the University of Colorado, which is a decision aid again for families to talk about. If you'll go to where it says the UC health version PDF. There you go. So this one actually is a tool that allows the families themselves to talk about what is going on life support during COVID pandemic mean, what is the ventilator, kind of walks you through it, and then prepares you for a discussion that's going to be facilitated by a clinician. So this is pre-clinical discussion, and also then questions you on whether or not, as Jessica mentioned, so who's your medical power of attorney, and actually prompts you to maybe make sure that that question is asked and answered before you're actually having to deal with a clinician. So these are facilitated conversations by social workers and others, and can sometimes even be handed directly to a family member who's very confident in being able to address some of this. And some of your families already have gone through these discussions. Okay, go back and then we'll pull up one other one. The Ariadne Labs one that she mentioned earlier is there on the right. These are actually facilitated conversations. They actually walk through the language and the conversations that I think that were highlighted by Dr. Kalender-Rich as well. So these are, again, guides, videos for families to watch, yourselves to watch, that kind of use as a tool to teach how to explore and have these conversations. Excellent resources, evidence-based, and significantly researched by Ariadne Labs and Dana-Farber and others in Boston. And then finally, the tip sheet from the center. If you want to go back, I'll just bring that up. The Caring Conversations, maybe it's on the top one, Matthew. There it is, the COVID tip sheet. And that's the one that we have. Again, this is a design for families to follow 6 steps on how to prepare them to have the resources, or excuse me, the questions asked and answered related to how to identify an agent and maybe have a discussion in identifying the goals of care through the expression of values and what's most important. And it's just a kind of a prompt thing. And then also has a link then to our ability to record, save, and store in the cloud those expressions that want to be shared by families. So that's it on the slides for the resources. All of those are available on our website by clicking on the shared decision-making tools. Okay, and then finally, I think, yeah, we've got contact information for me and Linda, and then also for Jessica. And so with that, I'll turn it over to Matthew, and we can start with the questions.
Yeah, so we're running a little long, and if our speakers have to jump off, that's all right. But we can keep at least the feed running for a couple of minutes if people have questions and would like to submit them. Just a recap, you can do that through the chat tool or the Q&A function, and I'll read them to our speakers. So thanks.
And while I've still got the mic, do you, Jessica, Linda, Maria, anybody?